Good afternoon, everybody. Welcome to the Independent Sage briefing. Last week, we noted that hospital admissions were on the rise, and unfortunately, these trends have continued. And in comparison to last week, the number of people admitted to hospitals with COVID in England has gone up by 37%. Along with the climb in people getting infected with COVID at large, not to mention the added burden of flu, the trend is worrying as we approach winter. As we at Independent Sage have continued to reiterate, the risk from COVID infection is not just about the acute symptoms, which can be quite mild for some people, but also about the long-lasting effects seen in people. Today, we're going to discuss one aspect of the long-term concerns associated with the SARS-CoV virus, and that's long COVID, and in children particularly. Before we get into that discussion, I would like to invite Professor Christina Pagel to kick off this briefing with a presentation of the latest COVID trends. Over to you, Christina.
Okay, so let me share my screen. So today I'm going to cover prevalence, very quickly go through variants, take a bit of a longer look at hospital data, a little bit on mitigations, and then just end with some data on children and long COVID to kind of lead into our special guest this week. So this is the latest data from the Office of National Statistics, which tests a random sample of people every week. So it doesn't depend on people coming forward for testing. Does it for all nations? There was a sampling method change on the 6th of August, and that means that data is now more lagged. It tends to be about 2 weeks old. And although this goes up to 20th of September for the other nations, for England, it only goes up to the 17th of September. So it is quite lagged for England. And what you see is that there's been quite a sharp increase in Wales. The trends in Scotland and Northern Ireland are less certain, and a kind of a small rise in England. But as I said, the England data only goes up to the 17th of September. If we look at it by age, then we see increases in every age group. This is England data only. So why is this? You know, is there some new variant causing this new wave as happened in the previous 3 waves this year? And the answer to that is no. What we have is a lot of Omicron, mostly Omicron BA.5 and its subvariants, but still some other Omicron variants knocking around. But what you're seeing is there's kind of this soup of variants, and they keep kind of coming up, taking over a bit, and something else comes along and takes over a bit. So at the moment, there are kind of 3 or 4 new variants that people are looking at. They're all subvariants of Omicron, and they're kind of called BQ.1.1, BA 2.75.2, and BN1. They're all quite new, and they are now increasing quite rapidly just this month. This is data that comes from the COG sequencing data in England, and the allocation to variants is done by Alex Selby. So thank him very much for sending it to me. So you can see this is increasing. It's still really small numbers, but we're not sequencing that many cases. And so right now we're kind of biased by if there's a cluster, for instance, in a care home, it might look like there's something really increasing fast, and it isn't. And there are also dozens of variants. So, you know, in August, we were worried about BE1 and BF7 and other BFs. And so who knows, in another week, we might be worried about something else. But the point is that we're seeing the kind of the variants that are around now, lots of smaller subvariants of Omicron are more immunoevasive than the ones from 6 months ago. So we're generally seeing a slightly more infectious form of Omicron around now than we saw 3 or 4 months ago. And if we look at hospital data, this is just the number of people in hospital per million people across the UK nations. This is kind of the only comparable data we have across all the home nations. For Scotland and Northern Ireland, it only goes up to the 22nd of September. For England and Wales, it goes up to the 27th. And you can see here that they are increasing in both Wales and England. In England, you know, the increase is more than we saw in ONS, but then ONS is more lagged. And looking at hospital admissions in England, you can see really there has been quite a steep increase. over the last week or two. We're already back at almost 1,000 admissions a day. And we're seeing that in every region. So there is regional variation. So you can see admissions are kind of highest in these regions, but even where it's relatively lower, like London and the east of England, we're still seeing rises. And when we look at ages, you can see here that this is adults only. But although it's going up for all ages, it's steepest in the 65 to 84 and over 85s group. And actually quite steep in the over 85s group. And there are people who most of them, or a lot of them, have now had their autumn booster as well. Now, there was kind of an interesting point picked up by Adele Groyer this week. She looks at the NHS data and tries to assign it into infections that are new and infections that might have been in hospital transmitted, so hospital acquired. And looking at the last 3 weeks, you can see this last week, there has been quite a big increase overall, but a bigger increase in hospital acquired infections. Now, some of this is just because we're not testing as much when people come in. So it looks like the hospital acquired, but actually they did come in with it. But some of it could also be because if there's less masking and less testing, there's going to be more transmission within hospital. And it could also explain why we're seeing more in the over 65s who are more likely to be in hospital. But if we look at it, the data by the number of people in hospital by primary reason, so are they there primarily because of COVID, which is the red plot, or for some other reason, which is the blue plot, you can see that both of them are going up. Both of them are going up quite fast. So it's certainly not just incidental admissions that's driving the increase that we see in hospital. So what about mitigations to try and address this new wave? The one that we're really doing is vaccinations, and that's the autumn booster campaign. It's currently for over 65s and over 75s in England. And it's progressing. You know, we've done 36% of the over 75s and a fifth of the 65 to 74-year-olds, which is certainly a decent chunk. And hopefully many more people will be getting it over the coming couple of weeks. Looking at the over 75, so kind of the most vulnerable age group for kind of bad COVID outcomes, they do have now a lot of protection. If you look at the combination of the autumn booster and the spring booster this year, you can see that actually most of them have that. So hopefully this will really kind of blunt the impact of this new wave in terms of deaths and serious hospital outcomes. But if we look at vaccine coverage, this is just first dose I'm looking at by age for the under 65s in England. This is a slightly different denominator, so it's not directly comparable, but you can see we have pretty high coverage for, you know, the over 50s. And then it goes down with age. But then for children, for the under 18s, you can see quite steep drop-offs, particularly for primary school children. We still have only 10% of primary school children have had 1 dose of vaccine. And there's more and more data coming out now about how effective it is at reducing hospitalizations in that age group. But other mitigations, we're not really doing. This is the latest ONS data. This is the percentage of people who say they wear face covering when they leave the home. And you can see that it's coming down and it's just kind of hovering over 20%. And in my view, that's probably a little bit, certainly still more than what I'm seeing when I go out. And you can see this has kept coming down. So, you know, public transport is now down at 10%. Why does it matter? Well, because really, you know, mitigations matter because people being able to work and lead their daily lives matters, right? It's not just about hospitals and deaths. And the FT this week ran a whole article about how can companies ensure a COVID-free workplace, right? It's not good for companies if their staff go off sick. And they talk about, you know, smart policies, ventilation, encourage people to get vaccination and so on. In fact, it's almost as if they'd read our safety pledge, which we will be coming back to in the coming weeks. So finally, just to kind of end on children and long COVID, this is just the kind of ONS infection survey over the last year and a bit, looking at the prevalence of COVID in school-aged children in England. So orange is primary school and blue is kind of secondary school, excluding A-level. And you can see here in the autumn of 2021, it was a big wave in secondary school children, slightly less in primary school children. But then a lot of secondary school children got their vaccine towards the end of 2021. And you can see that in the first half of this year, you saw these really, really large waves in primary school children who are unvaccinated and remain mostly unvaccinated. And then towards the end of last summer, or rather the July wave, you can see another school wave here. And this time it was actually higher in secondary school children. Likely these two massive waves have blunted the impact a little bit in primary school children. And yes, they're both now going up again. As of March 2022, the ONS School Infection Survey estimated that, over 82% of children in primary school had had COVID at least once. Almost all of them, well, all of them really, without the benefit of vaccination. And by March 22, 99% of secondary school pupils had antibodies for COVID. Most, about 60% have been vaccinated at this point. But so it's kind of a mixture of vaccination and infection. And this is just the latest long COVID data. This is infections up to July. You can see that the big waves, this is primary school children, 2 to 11-year-olds, the big waves early this year did lead to a big spike in long COVID. It is now coming down, I imagine, as some of that resolves. But this is, it's a big deal for a child to be sick for weeks on end. For secondary school children, for 12 to 16-year-olds, you can see similar big increase with the big school waves last year. And most recent data went up again, and potentially that reflects the July wave that we saw in secondary school children. And in terms of the impact, 13,000 children are reporting that it impacts their daily lives a lot, and 50,000 that it's a little. I mean, this is a lot of children who've been affected by having COVID. So just to summarize, there is a new wave underway. It's still in its early stages. It's more obvious in the hospital admission data than the ONS infection survey so far. There's no single variant behind it, but there are several that are growing, and the general super variants around now are better infecting people than a few months ago. The autumn booster uptake is good, and it should blunt the impact of the current wave in terms of severe outcomes. But please, if you're eligible for a vaccine, please go and take it, and including the flu vaccine. So you don't want to get flu this year either. But other mitigations really are not being done. Most children have been infected at least once by now. For under 11s, it's without the benefit of the vaccine. And that really is a consequence of high community transmission. We've had high community transmission in this country ever since the summer of 2021. We have not had adequate school protections, so children are getting infected. And also we have had late and under vaccination in these age groups. They haven't had the benefit that some adults have had of high vaccination rates. And I will end there.
Thank you very much, Christina. Now we're going to move on to our main session, and we're going to have a conversation about COVID and long COVID in children. We've got two special guests who've joined us for this, and a great welcome to you. And I'm going to invite Dr. Stephen Griffin to introduce our guests and coordinate this discussion. Over to you, Steve.
Thanks very much, Helen. I hope people can hear me okay, because I'm having to improvise on my phone today due to some technical issues. But as Helen says, we're here today to talk primarily about long COVID in children. And we've got two fantastic guests. One is Sammy McFarlane from the Long COVID Kids charity. And we've also got Steve Lowe, who's the head of the Oxford Hospital School. And we'll find out a bit more about that in a moment. So what we're going to talk about today is always an emotive subject, always, because when people start talking about children, and especially with respect to COVID, there's been a lot of debate around that. Because primarily there's this narrative around the fact that COVID doesn't really affect children. And we've just seen the numbers from Christina and shown that that's clearly not the case. But it's absolutely the fact that many people aren't really aware of the scale of the issue in children. And that's because we often talk about children's COVID in relation to adult disease, and we're not always aware on a population scale as to how severe these difficulties are that kids are experiencing. Now, we're not talking about acute disease primarily today, but it is a factor. Children do unfortunately get very unwell with COVID and die. they have other complications such as MIS-C. But there does seem to be even less awareness of long COVID in children. And as Christina said just towards the end there, the effect of a child, and this includes primary school children, of getting on well with this illness is massively profound. So we're going to talk about this. We're going to talk about long COVID kids. They're doing work with the WHO, for example. But first of all, I'm going to let someone called Kitty explain to us exactly what a problem long COVID in children is.
Lots of people have heard that kids can't get long COVID or COVID because they have strong immune systems, they're young and healthy, but that's not true. It doesn't matter how healthy the person is, anyone can get it. I'm 16, I was 14 when I got it, and I was a sporty, young, active teenager, and yet now, 28 months later, I'm still doing mainly bed rest.
Thank you. And that's just the typical example that Sammy and her charity are using in conjunction with the World Health Organization to try and promote the real problem associated with long COVID. So I'm going to talk to Sammy now about the work that she and long COVID kids have been doing. So welcome, Sammy. It's fantastic to have you on the briefing. It's really lovely to see you. Obviously, it would have been better if you're under better circumstances. But we've just seen the numbers from Christina, and they are troubling. And we know that long COVID kids keep a close eye on the facts and the figures as well. So, just go back over again and tell us how common is long COVID in children in the UK and across the world, and why do you think we don't hear about this really in the UK very much?
Hi, Stephen. Thanks for having me today. So, as Christina said, there's 98,000 children living with long COVID that the ONS reports, 30,000 of whom have had symptoms for at least a year. That figure went up by 4,000 in the last figure set. But what's really concerning is that 13,000 of those report that their symptoms impacted their activity levels a lot, and that's certainly consistent with what we see in our support services, and that's consistent with what I see in my own daughter. And actually, I'm feeling a bit more emotional than I thought I would be listening to her video, because her reality is that she's 29 months on, still living with the symptoms of long COVID, and they affect every single part of her life. In our support services, we're seeing the same thing over and over again. Children are getting ill, then they think they're getting better, then they sadly seem to relapse. And some children do make vast improvement, but we very rarely see stories reported of where they're completely recovered. We do get the odd one or two now, which we didn't get last year, but it sadly is few and far between. In terms of why I don't think we see the information in the media and well reported, I just think that the government didn't really acknowledge that children caught COVID, let alone that children would get long COVID. And the figures have been as high as 149,000 children living with long COVID, and I think it was April 22. And it's really an inconvenient truth, I think, honestly. The truth is that the pandemic did and does and is affecting children. Giving them post-viral illness isn't new. They're ending up with long-term disabling symptoms, and I think we could have thought this through a bit more than we did. The symptoms are chronic. They affect every part of their life, and there's very little formal guidance for the people that are caring for children, for caregivers, for educators, for health professionals, and unfortunately, the reality of the situation is that children are struggling.
No, absolutely, and it's dreadful, and it's really troubling as well, seeing the levels of vaccination in children that Christina showed us just before. And on the point of not being aware, we picked out, Independence Age picked out a section from the JCVI minutes from last June, where they're discussing long COVID in children and whether or not vaccines should be deployed about that. And they say, and bearing in mind JCVI can only really discuss the evidence they're given, but they say studies into long COVID showed only a small percentage difference in persisting symptoms between those who'd previously had COVID and those who had not. So there's a bit of an insinuation there, isn't there, that this seems to be all in the minds. And I've certainly seen certain quarters on social media try to imply the same thing. What would you and the children and the families that you're supporting say to that, Sammy?
I would say believe the children. They are the evidence, and children don't usually like to sit still. They usually like to run around, have fun and enjoy themselves. This isn't about a mental health illness. There are impacts of having a long-term health condition, and of course the longer a child is ill, the more it's going to affect their mental health. But they're organic causes, and we know that from the adult data, and we just have a data lag in research for children caused by that early narrative that children weren't affected, and sadly we're on catch-up.
So, again, as Christina mentioned, not only do we have low vaccination rates, but there's pretty much no mitigations in schools now either. So they may have a CO2 monitor, they might not know what to do when it goes red, but we're not hearing anything near enough about filtration and things like that. So what do families think about that in terms of, are children going back to school, or are they still staying at home because they're too unwell?
I think there's a genuine concern and a valid concern for families who have children with long COVID about sending them back to school when they start to show signs of improvement, because it takes so long to start to feel better that if you go back to school and then you're exposed to COVID again, or even another virus, there seems to be this increased immune response that we think seems to then set off another cascade of symptoms. So it's a genuine concern when families say that they're worried about returning to the classroom. All mitigations have been removed to protect children, and there's been no investment in improving indoor air quality, and that's really something that we need to see. And our reinfection survey that we published in collaboration with Long COVID Support actually showed the effect of reinfection on children. So many of them are then, when they are reinfected, are experiencing a significant relapse and more symptoms, sometimes new symptoms, or the old symptoms come back.
Oh, that's dreadful. So you mentioned about going back to school. There's a huge emphasis from the government and other vested interest groups about school attendance, and almost attendance at all costs, and obviously wanting to make the time up from the time missed at education is important. But how, we hear terms such as ghost children and all these sort of fairly derogatory terms about kids that have been unable to attend school. Given your experience of supporting families with children with long COVID, what should we be doing, or what should the Department of Education be doing to support children as they try to return back to their education? Because we should bear in mind that, if long COVID hits very young children, it's an acutely important developmental stage. And then, of course, later on, they have exams. So how are kids dealing with this?
Well, they're not. They're unfortunately being left alone and without education. I mean, this is the biggest challenge. We really need to reconsider the focus on attendance, I think. Schools are judged by Ofsted on their attendance figures, and by removing those sort of high stake accountability, then I think schools would be better able to support children. There's a general lack of awareness that children have long-term conditions, and how they might be able to access school. It's sort of, if you can't come in the way that they want you to come in, then there's very little support to have sort of hybrid or flexible learning models. And that's definitely something that we need to look at going forwards, because about 80% of the children in our support services are out of school, either completely or attending part-time and sporadically, and very few feel that their education needs are being met. And the ones that are attending really don't feel that it helps their health condition.
Absolutely. And it sounds dreadful. And, we heard about, people saying that it might all be in the mind, and then they're not being believed when they're saying that they're unwell. It sounds like a ridiculous set of circumstances, really. And of course, with no mitigations and the immune evasiveness of this virus, we're going to see more and more children infected, which, even if it's the smallest estimated risk, is still going to lead to tens of thousands of children getting long COVID again. So what should we look for in children? Is the symptomology different in children compared to adults? I mean, what are the sort of warning signs that you would pick out after they've had COVID and start complaining about problems?
So in terms of, is it different to adults and children? I think that's a yes and no question. Adults and children do share symptoms: pain, fatigue, post-exertional symptom exacerbation, the dysautonomias, for example. But I think in children we're seeing other symptoms. You know, the rashes are very common, some stomach upsets, gastrointestinal issues are very common, as well as neuropsychiatric symptoms. And we just don't know why that is. Is it because they're developing, you know, they're developing bodies? Is it because the additional high incidence of reinfection and continual assaults on their immune system, or is it something to do with the variants? You know, we need the research to find that out.
No, absolutely. And just lastly then, Sammy, tell us about what long COVID kids are doing, because you're doing an amazing job. A lot of it you're doing on your own, but there are obviously other charities involved, and now you've been working with the WHO. So tell us what's been going on.
So we try. We have an amazing team of volunteers, some of whom are professionals, some of whom are expert parents. Most of the people on the operational team either have long COVID themselves or have a child living with long COVID, or both. And we've learned a lot over the last 2 years. So we spend a lot of time obviously supporting the families, peer-to-peer support group, providing early intervention and guidance to signposting, which I think is really crucial. There's a lot of misunderstanding and a lot of myth busting that needs to be done. You know, some symptoms can be treated, and so children do need to see their medical practitioners as early as possible to try and see if they can get support for those symptoms. And they also need to have other conditions screened out. But we have sort of found lots of ways of helping families on a day-to-day basis to just improve their daily lives. And I think that's really where our volunteers are able to give their expertise. And we've created a number of resources, or one of which I happen to have here. So this is our support guide. It's 140 pages of knowledge sharing information, and well supported by lots of professionals and experts. And there's sections in there for schools, for parents, for children, young people themselves, and for healthcare practitioners. And we really want this information to get out. So please do go to our website, go to the support guide, download it. It's free. The digital version is free, and you can keep going and looking at it as many times as you want. And we hope to have further printed copies in the future. And in addition to that, we've got our resources in our blogs, but it's all evidenced and supported in our support guide. So it's the best place to start.
No, absolutely. And you're probably too honest and modest to mention the fact that you guys picked up a couple of awards this week for this sort of outreach and support, and absolutely thoroughly deserved. I mean, the fact that you are all volunteers and also living with children who are suffering from this condition is absolutely incredible. So thank you, Sammy. Thank you for all that you're doing. I'm now going to switch over to Steve, because Steve is involved with the running of something that I wasn't particularly aware of was happening, to be honest, and that is a school setting within a hospital. And we're going to hear from Steve now about what it is that he's been doing, and also how long COVID is impacting on their ability to conduct this in school. So Steve, really nice to welcome you to the briefing. Could you just tell us very quickly, you know, what your role is and what the hospital school in Oxford that you're running is actually doing at the moment?
Sure, yeah, thank you. Thanks for having me this afternoon, by the way. First and foremost, Section 19 of the Education Act requires all local authorities to make arrangements for young people who are too unwell to attend school. So that's the bottom line. So local authorities all have a duty to ensure that there's provision across the country for young people too unwell to attend school. Now, unfortunately, the guide that they now use, which is called Ensuring a Good Education for Children Who Can't Attend School Because of Health Reasons, was last updated in 2013 and doesn't really offer a particular template for local authorities to use. So there is a postcode lottery across the whole of the country. We're very fortunate in Oxfordshire, those of us in this meeting here now, and I know there are a few, in that we have a children's hospital. So there is more funding going into that piece of work locally than there is perhaps in other areas of the country where there aren't designated children's hospitals. So we work in inpatient settings in Oxford and across the county of Oxfordshire, but predominantly the work that we're doing with young people with long COVID is within our outreach team. So whilst we're working with young people who are inpatients, we have referrals to our outreach team from schools across the county of Oxfordshire, who have got concerns with young people who might have been absent for a significant period of time. And that's tricky for us to use because we have a limited amount of resources. The more referrals that we get in doesn't mean that we get more money from central government to support that piece of work that we're doing. We charge schools back for the service, but that doesn't cover our costs. So inevitably, we end up diluting the service for more children that we receive. We're funded for 45 across the county of Oxfordshire, and we're hitting those numbers now. The challenge for us, I guess, is that we're seeing an increasing number of young people being referred into our service with long COVID. Sometimes with chronic fatigue. There's a confusion sometimes in the diagnosis as well with professionals. And I spoke to Sammy last week, and I know she's in contact with other charities around chronic fatigue and ME as well. And that's tough. That's really difficult for us because it's like a new condition that we're now having to deal with. So it's not like, you know, we've got young people. We have half a dozen now across the county of Oxfordshire with long COVID that we're working with, and other referrals coming into the service as well. And it's not like there are other conditions that now don't exist. So these are in addition to those that have been there. So it is increasing the pressures on our services across the county. And it is not easy. We also work quite closely with the local hub in Oxford for treating young people with long COVID. It's one of the 15 regional hubs across the country. We've been working with them for some time. And that's really quite helpful. So yeah, it's an increasing pressure on our service.
That sounds really difficult, but it does sound as though Oxfordshire is possibly one of the better off in terms of places around the country. I mean, how common are these schools within children's hospitals around the country, Steve?
It's quite hit and miss, to be honest. I mean, like I said, all local authorities have to have a provision. Some of those provisions look like remote learning. Some of them, so there are a number of companies that will just charge young people, local authorities to engage in online lessons. So they will join a class of, you know, perhaps 20 or 30 with a tutor that they will never meet and perhaps not even see online, and be expected to engage in learning. Now, I know, and many others know, that those with long COVID are going to struggle with an hour's worth of a lesson online. They're going to need regular breaks. They're going to need time away from the screen. They're going to need, and they won't necessarily be able to work to a specific and set timetable, which again is one of the challenges that we're experiencing when I'm allocating my staff to travel around the county. It's a tough call for local authorities. Some of them do provide tuition, so they'll employ tutors to go to young people's homes. But again, that's in terms of long COVID and providing education for young people with long COVID, there are a lot of challenges associated with that because, like I said, we'll have a timetable and I'll send my team across the width and breadth of the county to provide tuition. But sometimes those lessons are cancelled because a young person is not well. We use telepresence robots as well, increasingly. So there may be a robot that sits in school that the young person can log into from home so they can communicate with their peers. Some of those robots are static and just sit on a desktop. Others can actually move around the school as well, so the young person can operate them, and they can go into social environments in the playground and walk along the corridors as well. So, you know, there's a lot of really good technology that's being used that's being deployed to support young people with medical conditions. But in this case, clearly those with long COVID. But it's a developing system that we all have as well.
No, absolutely. And is it worse in more deprived areas around the country, or is it just hit and miss, as you say?
Yeah, I've certainly not seen any statistics that exemplify the problems to any greater or lesser extent, to be honest. It'd be difficult for me to answer that with any real conviction. Okay, fair enough. So you've been working with Sammy and the long COVID kids teams. So tell us a little about how you've been interacting with them and working towards supporting their work and they're supporting your work. Well, it's a very new relationship, to be honest. I mean, I in the work that we're doing here was doing some research to work out what the best program of educational support would be for the children that are being referred into our service, because we can't keep on the way that we're working at the moment. It's not fair on the young people and it's not fair on our service. And through that research, I came across long COVID kids and reached out to the charity, and Sammy got back to me like within minutes almost, it felt. And we met last week and had a preliminary conversation about what their charity is doing. I'd looked at the support pack, which I have to say is fantastic. It really is a very, very good piece of work. There's a lot there, and certainly from, I think it's page 94 onwards, which is the schools section. I've taken that and I'm now distributing that to the schools that we're working with for their information. There's some great stuff in there. One of the next things that I plan to do, and we'll try and do some work with Sammy and her team as well on this. We have a website which provides training materials for schools and education professionals to assist them with young people with a variety of medical conditions. We currently don't have any materials on that website for long COVID, so I'm going to be putting together some resources within the next few weeks. And I will certainly be using some of Sammy's resources, because there's some remarkable stuff. There's no point in reinventing the wheel. There's some great stuff that sits within that resource pack. So we'll certainly be using that as we move forward. We've also started talking about the possibility of collaborating on online schools in the future, and whether or not there's any mileage in us working together to see whether or not we can provide some greater assistance and reach more children.
Great. So is there a central sort of area of knowledge that parents can access if perhaps they feel that they're not getting the support from the school that they otherwise should have? And can they just contact their local authority? Should they look at the Long COVID Kids website? What would you recommend if someone's struggling to get the support they need?
In the first instance, I would always say go back to your school where you're at. If you're not getting the support that you feel that you should be getting from them, because they have a duty as well under the Section 19 of the Education Act, there is a requirement on schools to ensure that they're making provision for the young people who can't attend for medical reasons. So that has to be the first port of call. The second place to go to then would be the local authority, because they, under Section 19, must have provision. They must provide for young people. Those authorities where there are hospital schools provisions, we're fortunate in Oxfordshire. It's very strong. There are a number across London. Northamptonshire is very good service, Leicestershire, Bristol. I have colleagues all around the country. We have a national association, the National Association of Hospital Education, for which I'm a director. We have a website, so by all means go to that website and contact the hospital schools directly if you're aware of the one that sits within your local authority. They will then point you in the right direction. You can't self-refer into those organisations, but you can at least get signposted to where you can be provided with that additional support and information.
That's fantastic. Thanks, Steve. And so, it all seems to be quite, it's great there's a national association, but is the support on a national level from government sufficient for you guys to keep doing what you're doing, and what needs to be invested to make this sort of future-proof going forward if you're going to continue to see long COVID children coming into your classes?
First and foremost, there needs to be a national template for schools, local authorities. There needs to be some consistency, because at the moment it is a postcode lottery. And the question that you asked around, what does it look like in deprived areas? And there is not any research, as far as I'm aware, that looks at the impact on education in deprived areas. We talk a lot about social mobility and levelling up, but the challenge that we have at the moment is that we're not moving fast enough. So we need to work together to create a national template around this. I mean, from our sector particularly, we talk about multiple medical conditions. The one that's challenging us at the moment, and that it is long COVID, but we need a national model on this, and we need to act on this quickly as well. Otherwise, we'll be reacting to a situation rather than, arguably we already are. But we can see the problem increasing from our position and perspective at the moment, and it's not going to get better quickly, for sure.
No, absolutely right. Well, thanks, Steve. Absolutely fascinating. Brilliant to understand more about the sort of help that kids can access in this situation. So thank you. And thank you for all the work you're doing with these children who really, really do need so much support. So with that, thank you both of our guests for some fantastic insight into what can be done to support these children who are struggling with long COVID. And I will hand back over to Helen, who's going to field the questions from the public. Over to you, Helen.
Hello again, everybody. Thank you. That was an absolutely fascinating discussion, and really interesting to hear what resources are out there. What we'd like to do now is to move on to the next part of our briefing and to take some questions and try to answer them. And we've got some people here on the call who are here to ask us questions. The first is Melissa Brandsberg. Would you like to ask us your question?
Hi, thanks for having me today. I really appreciate it. So I'm a mom to a toddler who was born in a pandemic, born in lockdown, and is completely ineligible for any vaccination in the UK. So beyond that being frustrating, I've heard so much about the discussion around clean air in classrooms, ventilating classrooms, mitigation in classrooms, but I've not heard any conversation about what nurseries can do and how can we keep our littlest kids safe in nursery, where we already know nurseries are kind of a cesspool of infection of all sorts anyways. So what can parents ask in those care providing areas for keeping our children safe? And I was just kind of really wondering what happened to the precautionary principle for our little kids whose immune systems aren't yet developed until they're 7, and how can we be keeping them safe, especially without the main mitigation of vaccination?
I think that's a really good question. Who on our panel would like to address that question? Professor Mickey, can I go to you first?
Well, I'll start off, and just to say that the most important thing for any indoor environment is to make sure that the air quality is safe. So first of all, ventilate where you can ventilate. Obviously, as the cold and the winter comes, that's a problem. But also, where it's not possible, where it's not sufficient, look at getting air filtration units into them. They're not massively expensive. Obviously, everybody's struggling and nurseries are struggling, but they can really make a big difference. There have been trials comparing different wards in I think it was Addenbrooke's, Cambridge Hospital, really showing big differences of rates between patients getting COVID, where there were air filtration units compared to where there aren't. So I'll start off with those two. Very obvious, but it really applies to every single building, whoever's in the buildings.
Thank you, Susan. Anything else we have to add to that? Anthony, Professor Costello.
Just to say that under 5s, I mean, no government that I know of is vaccinating under 5s. And one of the reasons for that is that much younger children don't have the receptors for the virus and generally get very, very mild or asymptomatic infections. And so the issue there is they will be being exposed. Very few of them will get sick at all. And they will be building up some immunity as they go. The other thing, of course, is that the first 1,000 days is probably the most important time for child development and for beginning of social interactions and getting together. So I think nursery, education is incredibly important. But I endorse what Susan says, that, there's no reason why we can't apply the same rules to nurseries as primary schools. But I would be reassured that your child is not going to get very sick, put it that way.
Though, Anthony, I have to correct you. It's been pointed out the US is now vaccinating little ones, I think, from 6 months on. Zubaida.
Just very quickly,
really? I didn't know that. Have they done the trials of vaccines at that age? Or have they just decided to? I mean, there is an argument for it. I can see that, but
there are trials. Yeah, I think it's Pfizer again.
Yeah.
What I was going to say is, I've said this 1,000 times, and we know this, which is that children are not a homogenous group. We've known this from the risk factors. When you look at children in deprived areas, when you look at adults in deprived areas, there's just different risk factors for adults, which apply, to a great extent as well to children. And one of the things we know is that in deprived areas, there's a lot less green space. In deprived areas, children are living in flats that are not very well ventilated. There isn't that green space and so on. The risks are much higher. So it goes back to the fact that if children and adults, if families can't take that personal responsibility of protecting children because of the circumstances that they live in, then it's a stronger argument to vaccinate. It's a stronger argument to be vaccinating younger children who are exposed, quite a lot in schools and so on. So it's great, actually. I'm pleased that the US are at least vaccinating younger children.
And just before we go on to our next question, Steve Griffin, you had a word to say.
Yeah, just to follow up on the idea of vaccinating younger children. Anthony's right, the vast majority won't get serious disease, but there is, on a population scale, a kind of U-shaped risk curve for children, and very young children can develop something called MIS-C, so multi-inflammatory syndrome in children following COVID infection, several weeks afterwards. And the trials that were done in the US and elsewhere have shown that that condition is mitigated by vaccination. And the other thing that the vaccination we infer mitigates from adults is long COVID. So there certainly have been several risk assessments done on both the 5 to 11-year-olds, which JCVI approved in the UK, but has now for some reason stopped endorsing, for kids that turned 5 in September, and for younger children. So I really think that a campaign targeting, supporting children vaccination is something that we should look towards doing in this country as urgently as we possibly can to keep up with the other countries across the planet.
Sorry, Helen, can I just correct my statement because I'm out of touch and been interviewing all morning. The US, Argentina, Bahrain, Chile, China, Cuba, Hong Kong, Emirates and Venezuela are offering COVID vaccines under 5. So it's quite a few countries. And there is an argument for it. I'm not saying there isn't.
Thank you. Sammy, did you want to come in on this as well?
Thank you. Yes, I was just going to say that that the Royal College of Paediatric Child Health did a review called Health Effects of Indoor Air Quality on Children and Young People in January 2020. And I think that's a really good document to have a look at because it talks a lot there about the health and learning outcomes that can be improved with improved indoor air. So if you're having conversations with people at your nurseries, at your schools, then I think that's a great document to kind of put forward as a really good reason for why they ought to be investing in improving indoor air quality. Thanks.
Thank you so much for your question, Melissa. And now we're going to move on to Gary Hatz. Gary, are you there?
I am indeed, yes. Thank you for having me. My question is that if we encounter any new variants that avoid immune systems this winter, how would we deal with this?
Right, really interesting question. I think, Professor Allman, this might be one for you.
Yeah, no, it's a great question. So the answer is, it's been a kind of ongoing war of attrition, hasn't it? So at the beginning, we thought we were really smart and really did have magnificent vaccines that really were. And then we continue the arms race against the virus and it mutates a bit more and a bit more and a bit more. I think in the end, I'm slightly less worried than you are because I've got faith in our immune system that there are an awful lot of bits of that virus that can be recognized. And I don't think it can completely evade our immunity without too high a cost to its own survival. So I think, I think we'll always win the arms race, but it doesn't always feel like that. I hope that helps a bit.
Yes, it does. Thank you for your answer. Thank you.
Any more on this one? Shall we move on? Okay. In which case, Terry McGinnity, you there? Hello, do tell us your question.
Yeah, hi. Yeah, I have. Thanks, IndieSage, for all you've done. I had my booster the other day. Although I self-tested negative, I think now I might have had some of the symptoms of COVID, however mild. Recent advice seems to be to wait for at least 2 months before taking the booster after contracting the virus. Should patients wait if they are unsure, or is it better to take the booster as soon as possible? Is the 2-month gap prescribed because there's a need not to overload the immune system?
Right. Who would like to take this one on? I Steve Griffin.
Yeah, so the gaps between infections and vaccination are primarily due to the very small risk of myocarditis, and that tends to be the case. But also, you don't want two stimulations of your immune system too close together, because that won't actually give you any additional benefit in terms of immunity. So the fact that you had your vaccine before you then started feeling unwell, there's not much you can do about that. So you're just going to have to deal with that. It would have taken a little while for the response to the vaccine to kick in. You may well have caught it in the vaccination centre itself if people weren't wearing masks and it wasn't properly ventilated. So there's not much you can do about it. I wouldn't worry about it. It's great that your symptoms are mild, but yeah, follow the government advice if you can. If you know that you were infected, then you should wait for your vaccination for those reasons.
And one issue is that I think a lot of people don't know they've been infected or when they've been infected because there's less testing going on. So there's so much uncertainty there. Any other thoughts on this question? Professor Greenhalgh.
Yeah, just a very kind of basic message from a general practitioner. If you are ill on the day that your vaccination is due, don't go. It doesn't matter whether you're ill with COVID or whether you've got some other illness. You want to be fit and well when you have that jab, and the immunologists will tell you why. But certainly, as someone who's been a GP for a while, we wouldn't want you coming in for your jab if you had a fever in particular.
Quite just right. Is it possible that his symptoms were linked to the booster? When I had my booster, for about 3 or 4 days afterwards, I had a return of fatigue and feeling a bit unwell, and some of my friends have reported that as well. Is that the experience of others like Helen, who sees a lot, or Trish?
I think Helen will have to answer that.
Yes, I mean lots of people do feel unwell having had the booster for a day or two and feel feverish and fatigued, and may not, they may actually be a bit similar to some of the symptoms you get from COVID itself. I would also add to Trish's question, if you're not well on the day before you set out to go and get your injection, it might not do the best for you, but certainly we don't want you coming to the vaccination centre and giving it to other people. So do make sure you're well and not feverish when you come to get your jab. I hope that answered your question, Terry. We're going to move on to the next question, which I'll read out. This is from Sarah Humphreys, and she asks, are autoimmune conditions in children on the increase since COVID? Is it the infection itself or the lack of immune exposure because of lockdowns that are possibly causing this? Does anyone have any data on this and able to answer?
I can make a start if you like.
Thank you very much.
So let's unpick the two parts of that. Is it lack of exposure during lockdown? I think you often hear it discussed, and as an immunologist of too many decades standing, it's not really a thing. So the idea that your immune response goes into some sort of dysregulation because you've been in lockdown and haven't been stimulating it, really, to somebody like me who researches this every day, really isn't a thing that I worry about or think about, or that there is any data for. So not that, I think I can say safely. And then I wish I knew more about new patterns of autoimmunity in children as a consequence of COVID. I don't. I know quite a lot about patterns of autoimmunity in general as a consequence of COVID, and everybody who's looked at it, including us, has picked up quite a lot. And it's a thing that the virus does. And if it can do it in adults, I suppose I don't really see why it can't do it in children.
What sort of autoimmune conditions have you seen more of, Danny?
Well, so because of the kind of study we're doing, we're screening for patterns of autoantibodies, and so between us and all the other labs, so many things have been picked up, haven't they? Anti-interferons, panels of antibodies that look a bit like lupus panels, a bit like arthritis, a bit like diabetes. So lots of different things popping up.
Okay, that's really interesting. Anyone else have more to add? Right, in which case, I'm going to go on to our next question, which is from Fran Mosley. What determines the severity of COVID? Is it linked to how much viral load one picks up? If it's less severe, is it because one's immune system is primed with vaccinations and previous infections? And does severity of infection have any bearing on predicting the severity for future infections? Dr. Stephen Griffin.
Yeah, so this is a really important point, because much of what we've heard through 2022 is Omicron is mild, okay? And that unfortunately is contextual, because any disease is an interaction between the virus or the other sort of pathogen that's making you unwell, your immunity, and also your environment. But yes, the virus load of inoculation can make a difference, but it's quite hard to measure that. And actually, we know that this virus is so incredibly infectious that very small amounts can start an infection off. But certainly if you have a really massive exposure, that can make a difference. So what we're in is a dynamic situation. We have immunity that is ebbing and flowing because of vaccines and boosters and exposure to infection. We've got a virus that does change its behavior. It evades our antibodies. It can counteract our, what we call our innate immune defenses sometimes, which are kind of the bells and whistles and traps that stop it at the beginning. And of course, the higher the level of immunity that we have, the better off we are generally as a population, but that population has variability. And the importance of immunity can be seen because when there have been populations that haven't been well vaccinated or exposed and they experienced an Omicron wave, and a big example of that was Hong Kong quite recently this year, Omicron was equally as devastating as the original SARS-CoV-2 that came out of China. It may not be as devastating as the Delta variant, which was a real beast, but Omicron really is perfectly capable of causing disease. And then the third element to that is our environment. So if you have underlying conditions, if you're slightly older, if you are taking medications that suppress your immune response or have had a bone marrow transplant, things like that, that really does affect that interaction quite profoundly. So severity is not something that's just dependent on the virus. So it's really quite wrong to say that Omicron is mild. Omicron tends to cause less hospitalizations in adults, not in children, in a well-vaccinated population. So it really is quite disturbing to continue this narrative that this virus doesn't make people ill, because we can see that in the hospitalizations going up, as Christina showed us at the beginning.
And I think we may have time to fit in one more question, which is from Daisy, who asks, in the case of children with persistent symptoms post-COVID infection who are not allowed vaccines yet, i.e. aged less than 5 years, is there any data as to whether the vaccine can worsen the existing condition if taken now? The current fear is reinfection and it's terrifying, but will the vaccine offer hope? So we've talked a bit about vaccines in this age group already, but particularly the combination of vaccine and pre-existing long COVID. Would anyone else like to talk about that one? Professor Greenhalgh.
Yeah, we wrote an editorial in the British Medical Journal about this, and it's the research literature is a bit confusing overall, and on average, if you've got long COVID and you have a vaccination, it's more likely to improve you than make you worse. But mostly, the most likely thing is it won't make any difference. And it's just possible, if you're in an unlucky 10%, that it might make you worse. Now, we don't know why. What would be really good is if we could predict the people with long COVID who would improve on a booster or on a vaccine, and also predict the ones who would get worse. But at the moment, we can't do that. I've just received notice that we've got a little bit of funding to do a bit of research on that. We're going to collect the stories of people who were made worse with a vaccine and who also those who got better on a vaccine. And we're going to see if we can actually use those narratives to link up with some of the biochemical and cellular mechanisms of long COVID. But at the moment, it's a little bit of Russian roulette.
I wondered, Sammy, whether you had experiences from your from all the long COVID kids who you hear and the families you hear from?
So I can give you what I know anecdotally. We have done a reinfection survey, but I will admit that I don't know this figure off the top of my head. But what I can say is that 82% of child respondents first got long COVID after their first infection, 17% after the second infection, and 1% after their third infection. And we think the 1% is because it was obviously when we did the survey, not that many people had been infected 3 times that took part in our survey, and we'd like to expand on that data. But in terms of vaccination affecting the long COVID, what I see in the support group is a mixed bag, honestly, of what people say. So it can. Some people say it helps with their long COVID. Other people say that it exacerbates their symptoms. Some people say it exacerbates it for a short period of time. But vaccination is the only way to reduce the risk of severe disease. So and hopefully has some benefits of reducing long COVID. So that's kind of as much as I can say. Sorry.
Thank you. And certainly the interviews I've seen with people with long COVID, this is adults, not children, it is absolutely this mixed bag, with some people saying I felt much worse, but others saying the sun came out from behind the clouds, the fog lifted, I felt well again on having their jab. So it really is very, very unpredictable what that vaccine will do in people who have long COVID, but it may stop you getting another dose of COVID, which I think is really quite important. I think we may have run out of time. Thank you so much, particularly to our guests, Steve Lowe and Sammy McFarlane. Thank you very much for coming to join us, and thank you to Steve Griffin for putting together this session. We'll be back again same time next week to answer more of your COVID questions.
Thank you. Great
Cheers.
session.
Bye-bye.
Bye.
Great session.